So welcome to Endoscopy Essentials next episode. Michael Bourke is back. Very happy to welcome you again. Hi, Michael.
Hi, Thomas. Great pleasure to be here.
So you have shown almost everything. There's still more to come, but the basics about hot, cold EMR, large lesions, etc. Now we're getting to the real danger because it all looks so easy, but there is this thing, the elephant in the room is perforation. So let's talk about perforation, how maybe to avoid it, how the defect should look like, and I'm really looking forward to this.
Yes, me too. Yeah. By way of background, what led us down the path to understand perforation was the terrible feeling when you walk out to recovery and you see a patient there grimacing with abdominal pain. And in the old days, 15 years ago, 20 years ago, we didn't know whether they had a perforation or not. Did they have serositis? At that time we were using air. Was it just distension? And that really inspired us to try and understand how we could better substratify the risk of perforation and understand what was going on at that critical moment.
By looking at the resection side first, of course.
Exactly. Yeah. By understanding the resection defect. That was the critical thing. And it came to us just by making lots of images. And at that time, 15 years ago, we had to print all the images, more than 15 years ago. We had to print all the images and we put them up on a board, on a cork board behind us where we did all the reporting, and there were hundreds of them. And we walk past them all the time. We go, that's different to that. And that led us to the discovery of the target sign. And it allowed me to understand how the defect should look and how to stratify all that.
So what's a normal defect?
Well, this example that we have in front of us, this is a granular lesion 2A plus 1S. There's a bit of lateral extension. And after it's been removed, you can see a beautiful image down here on the left with a wide submucosal defect. And so the submucosa is a bland blue mat of intersecting loose areolar connective tissue, which is a potential space. So when you make a submucosal injection, that potential space is expanded, and after the resection, it flattens out, and then you have these fibers that lie over the muscle. They're intersecting fibers, they're not parallel to each other, and they're avid for the blue dye indigo carmine. So it preferentially stains the submucosa, but it doesn't stain the muscle layer. So when you look at a normal post-EMR defect, you should see this bland blue mat of intersecting fibers with occasional vessels. If you're in the right colon, you might see a bit of fat. You see a vessel in the foreground here, another vessel over here, but this is the bland blue mat of the submucosal defect, or what we call deep DMI type 0, or submucosal defect type 0. There's nothing really going on, although there is a little bit of visible muscle here.
Yes, that I wanted to ask. So if everything is shiny blue, it's perfect. You have to take a close look.
Shiny blue intersecting fibers.
Yes, yes.
It's all blue, homogeneous,
yeah.
Relatively homogeneous, with a few blood vessels, you're fine. But what you really should do, because it will happen, avoiding perforation in complex resection, of course you can do things to avoid perforation, but like adversity in life, it's inevitable. There will be perforations. And the key thing is how you respond and do you recognize them. And what you must do at the end of every procedure is look at the defect very carefully, expand it fully with the water jet or by further injection and gas insufflation with CO2, and take extensive images, take a lot of pictures, because they're going to serve as your record to know when you go to recovery half an hour later and you see that patient grimacing, the first thing you'll do, you make sure the patient's stable, examine them, talk to the nurses and so on, give pain relief, but come back and look at your images. And your images will tell you whether there's a problem with your resection.
So the tendency, oh, thanks God, it's over, let's run away quickly, is the wrong one, right?
The wrong one. And in the old days too, when we made a little hole, we'd sort of, because we didn't have reliable tissue closure. And now tissue closure is at a level that we deliberately make holes all the time and close them up without I mean, the nurses are still talking about their weekend. No one even notices what's gone on.
So tell me about if muscular tissue is visible.
Yeah.
Is that one thing you also mentioned? You re-inject.
Yeah.
With the needle in, right?
With the needle retracted.
Yes.
Yeah. So here, if we look at this picture again, you'll see here down the bottom we see the parallel fibres, the white or grey fibres of the muscle layer. They're parallel to one another. They're obviously different to the bland blue mat of the submucosa, and they're not avid for the dye. So this is exposed muscle. So we call that DMI type 1. It's of limited relevance, but it's part of the classification which was published in Gut in 2016. Nick Burgess is the first author, my colleague. And this is important to understand. That you look at that and you say, well, I know what that is. That's visible muscle. And
would you try to inject a little bit, whether it elevates or
no?
If you see that, there's no use.
Well, if you see that, it's a point of interest to actually, because there will be a thin layer of submucosal tissue overlying it. So it's a point of interest to actually do this technique we call TSC, topical submucosal chromoendoscopy. So with the needle retracted, you just irrigate blue dye over that surface, indigo carmine, and you can see in the final image that dye, the areolar tissue there, the submucosa is avid for the dye, and you get this uniform staining. So we showed in a paper that we published 10 years ago in 2014 that when we did this interrogating defects, we were able to identify small perforations that we hadn't previously seen and close them and eliminate the problem.
So that means in your classification, if you name this a type 1, you make this a type 0 again by...
Yeah, that's true. That's true. Yeah.
Okay,
yeah.
Good. And if it doesn't stain, is that worrisome? If there are no whitish damage occurring?
If it doesn't stain, then it could be exposed muscle, or it might be submucosal fibrosis, which usually has a sort of bumpy, yellow appearance. And that, when you see submucosal fibrosis, that's important because that means that you cannot interrogate the muscle layer, and that there may be thermal injury to the muscle layer as a result of the adherence of the mucosa, the submucosa, and the muscle together, and there will be a risk of delayed perforation. If you look at this, these series of pictures here down the bottom, if that patient went out to recovery and had pain, I know 100% that, I mean, there might be another reason that the patient's unwell. Extramural injection, perforation elsewhere, gaseous distension, but this patient is not unwell because of the EMR per se. Yeah.
But the exposed muscular layer, so you're type 1, if it looks nice,
it's fine.
Fine.
You don't have to act on that.
Yeah.
So
okay.
Yeah.
Good.
Yeah.
So that's normal. 0 and 1.
0 and 1 are normal. Yes.
Yeah. Okay.
You don't see 1 so often. I mean, you most commonly just see 0 all the time. Yeah.
So type 2, is it dangerous? How does it look like?
Here's a good example. So type 2, just contrast type 0, type 1 with type 2. So this is a typical type 2. You can't tell, we don't know if we've injured the muscle there. It's really a charred mess because of the fibrosis. I think this was a scarred polyp overlying an anastomosis. And under those circumstances, and in this day and age, it's acceptable to be very aggressive and you in an expert centre, you needn't worry about making a hole. You don't want to, but if you do, you've just got to recognise it. But if you generate a type 2 injury, then this is the appearance. You have this yellow, denatured appearance to the muscle layer. There's submucosal fibrosis, which appears yellow to white. And you can't be sure that there's not deep injury to the muscle.
So it gives in after a day or half a day. And
it definitely, in this paper that we'll come to, it definitely is a risk factor for delayed perforation. So
and it mostly happens in treatment of recurrences or in fibrosis for what reason ever, But
Yeah,
probably not in a normal polypectomy. So
no. So if you see,
if you see that, you have used too much current, or you were too long.
You don't generally see it.
Yeah.
So 50% of lesions are flat granular lesions in general, and you normally get a beautiful type 0 resection defect. But some lesions exhibit submucosal fibrosis to their inherent biology, so they're generally flat, non-granular lesions, often found in the transverse colon. They may have pseudodepression, and they often have quite a bit of submucosal fibrosis. But the worst example is always seen with previous attempts. You see, a lot of scarring. You start in the, in the non-scarred area, and when you end up in the scarred area, you get this dense submucosal fibrosis, and that is definitely a risk factor for delayed perforation, because you may have injured the muscle without knowing, because it's tacked onto the mucosa.
So type 2 is linked to fibrosis, mostly.
Type 2 is fibrosis, and when you see that, then that is a strong indication for complete closure of the area of the type 2. You don't need to close the whole defect, because the whole defect could be vast, but the area of type 2 needs to be closed. And as you can see in this picture down here, we've systematically gone across and closed that with the clips very closely opposed.
So we're getting to closure later in detail, but the message here is you can close an area within the muscular defect, right?
Yes, that's right. Yeah. I mean, the thing about the colon...
As long as you get normal muscular tissue.
Yeah. The thing about the colon is it is very different to the other organs, and they require their own discussion in terms of closure. But in the colon, outside of the rectum, the wall is pliable and mobile. You can reduce the tension within the lumen, aspirate gas, get the wall to bounce up within the clip, and then close with the hilt buried on the tissue, and you can get that beautiful closure like we have here.
Now we get to the most interesting type, right?
Yeah.
Type 3.
Type 3, yeah. This is what started us on this journey, type 3, the target sign. So we realized that when we were looking at this, 15, 16, 17 years ago, you see, why have we got a white cautery ring inside the white cautery ring of the mucosal excision?
And you don't see a hole.
You don't see a hole, no. You don't see a hole. And the reason you don't see a hole is because everything is cinched together. When you apply the snare, close, diathermy, everything is cinched together. But the white cautery, this is the white cautery ring of mucosal excision. And if you see another white cautery ring inside of that, that is the white cautery ring of muscle incision. You've excised the muscle. And that means that the patient could go to recovery, they might even go home, but they will get a delayed perforation.
So if you sit there as a little dwarf and watching for hours, eventually it might open up, or it has a high likelihood.
Yeah. If you were to satisfy your curiosity, if you use the water jet on that and put a bit of gas, it'll open up
immediately
after a few minutes. Yeah.
Is that the Burns syndrome? The Burns syndrome, the post-polypectomy syndrome?
No.
I mean, maybe because that's from the old days. Maybe that's based on
No, so the post-polypectomy coagulation syndrome is due to transmural thermal injury without excisional perforation. Because if you have this type of perforation, unless it's a part of a retroperitoneal, so the colon's partly retroperitoneal in certain places, ascending, descending, so on. But if you have this perforation, this type of injury on the peritoneal side of any part of the colon, you will get a devastating free perforation at some point with a big leak. And if you don't recognise it, the patient will need surgery. Yeah. And the other way you can be sure about what you've done, so this is the defect target, and this is the specimen target. So intraluminally, the clue to the fact that you may have created DMI type 3 is slow transection. So you close the snare, we check mobility, it seems fine, and then as you cut through, there's a stalling in the transection. It takes more taps to go through, and then you see the defect. You mightn't see a hole or a type 3 injury, but if you take the specimen and turn it over intraluminally with the snare, if you see this appearance, you know that you've excised muscle, and sometimes it's just the tiniest bit. And so this patient will have, they've got a type 3 injury and they're at serious risk of a delayed perforation.
Again, closure, of course.
Closure, 100%.
If the defect is big,
just close it. We can show some videos to cover it. Yeah, but you just close the defect itself. So we would close first clip here and then straight across like that.
Okay. So if you can catch the mucosa like here, it's fine. But if the whole
not,
defect
just
is bigger,
catch the muscle.
With maybe here small clips even, no?
Yeah, you can downsize. Yeah, perfectly. Okay. Yeah.
So that's the main message. Watch out for type 3.
Yeah, but I think I would say the main message is extensively photo document the defect and classify the defect and have like 5, 8, 10 images, and then if the patient has pain later, then you can always refer to that and reassure yourself. It'll inform the approach. Does the patient need a CT? Did you close the thing properly?
But if you see the double rim act,
if you see a target like this, then you have muscle injury.
Yes.
Yeah.
Good. Now it gets easier because you see a hole.
Yeah, correct. So type 4 is a visible hole. You can look through and you have a hole when you see another structure moving independently behind. This is because sometimes you look and you think, is that a hole? Even a tiny thing. But if you see something sliding independently of the luminal structures, there's a hole. In the era of air, this is a disaster because the patient would very quickly get a tension situation within a minute or two, a couple of minutes. But in the era of CO2, it's not a major problem, provided in the stomach we sometimes have holes that stay open for half an hour, 40 minutes, doesn't matter. But in the colon, of course, you want to close it because there's a risk of contamination, so you close it up pretty much straight away. But in this example down here, we would resect the adjacent tissue, and provided the patient was stable, which they generally are, and the fluid pool needs to be opposite the hole so that you're not going to contaminate the hole. And we always give buscopan as well, because hyoscine, because sometimes you can get a bout of motility that'll sweep the scope away from the hole, and that's a real problem. So work efficiently, resect the adjacent tissue, and then close the defect.
That's another very important message. So if you have half of the polyp resected and you have your hole at the margin, you would go on.
Yes.
That you get some distance and then you close it.
Yeah.
And then maybe you finalize. Depending.
Yeah, because if you think about the scenario, you're going to close the hole, right? If we accept you're going to do that, you think about the scenario in recovery, the patient wakes up, they're there with their loved one, and you say, well, I've got some good news and some bad news. We made a hole, but we closed it. And the patient will say, well, what about the polyp? And you say, well, we'll have to get you back and do that another time.
Which is then much more difficult.
It's much more difficult. It doesn't fly. So if you're an experienced endoscopist in a stable environment with a good team around you, then please do remove the adjacent polyp and then close it up. Yeah, and we have a paper showing that.
But we have come quite a way, In the old days, make a hole, run out of the room and call the surgeon, right?
Yeah. And
then make a hole, close it and run away. And now stay there, go on and then close it, right?
And also we have, now we deliberately make holes,
That's the next step, yes.
Yeah, that's the next step, yeah.
Okay, wonderful. So I think we have understood the classification and we end here with a cliffhanger, how to close next time. Thank you, Michael.
Thank you.